Hello, everybody. Welcome to our session, Top 5 Innovative Ideas for Healthcare Centers in 2026 with Dr. Jason Lord. Thank you so much for coming today. Today's session is available for CME credit, and so you can use that. And also, we have a survey at the end that we would like for you to take. Thank you all so much for being here today, and I'm going to hand it off to Dr. Lord.
Good morning. It's a pleasure to be with you folks this morning. Just grateful to be able to share kind of a few things that our clinic has done in the last year or two. And believe me, there's no way that innovative ideas are not something that is the kind of heartbeat of FQHCs and free and charitable clinics. I know that constantly having to think of innovative things, and we know that many of us are impacted this year or even in the next 6 or 12 months by a lot of things going on at government levels that are going to impact patients. We have to constantly be thinking about innovative. So I'd love to hear from you folks what you guys are doing as well, as I'm sharing a couple things that I think could be blessings for different situations, depending on what folks are going through. Because, when we've had obstacles, we're just trying to figure out how to overcome those obstacles. So that's what I'm going to share. So a little bit about SAC Health. What is this? I don't know what's talking. What is? I think that I have no clue what I have in the background. I don't think I have anything. It's like talking. This is weird. Why is it talking? Okay, stopped. It stopped talking. Why was it talking? Why is it doing that? I'm going to turn off the volume. I'm just going to turn off the volume because it's saying something. Okay, maybe that's better. So we have been a faith-based Christian FQ only for the last 5 years. And previously we were kind of a community clinic that was associated with a large academic medical center, which happens to be Christian. But interestingly, when the Christian medical center started the community clinic, they made it specifically non-faith-based because they wanted it to be able to receive more grant funding. But we changed that 5 years ago and made it very overtly and intentionally Christian and faith-based. Our UDS numbers from last year, about close to 62,000 unique patients and 280,000 visits. We partner with Loma Linda University. It's a large academic medical center in Southern California, a large medical school and dental school and other schools as well. We have a lot of specialties. That's a huge blessing for our patients, 45 different specialties. And that's a huge blessing that our patients can stay within the system and see our specialist. And it's great for me as a primary care doctor to be able to walk down the hallway, talk to OBGYN, talk to endocrine, talk to rheumatology, talk to neurology, talk to ENT, ortho. It's just amazing to be able to have that. And of course, then because of that specialty care, we serve a geographic region of California, about 25% of geographic region of California. Patients drive 5 hours to come and see our specialty care, which is crazy when you think about it. But that's not uncommon in some kind of more rural areas. And 80% of California is rural, even though most people would never know it based on what we think about California. But most people live along the coast, and the farther away you get from the coast, the more rural you get in California. We have a teaching health center. We have 500 medical residents. It's very large that come through our FQHC to do their continuity clinic, and then all the different specialties. So when we're talking about some of the ideas that we've had the last 1 or 2 years, in different areas, we're going to focus on operations, clinical workflow, improving access to care, then leveraging technology and AI tools. That's a huge thing right now over the last probably 12 months or 18 months, and then even finance. So hopefully this is something that is broad enough that no matter whether you're a CFO or a COO or a clinician or a manager, one of these could be something that could be helpful. When it comes to operations, we created an efficiency in both our front office and our back office workflows that actually helped to grow our visit volume by 20% without the same clinical footprint. This was key because we actually had some folks come because we were expanding into a new clinic, and a team came and they were designing kind of our new clinic, but they looked and they said, you are inefficient with your current space. And we thought we were very efficient. Like, we were convinced we were super efficient. And they said, no, you're inefficient compared to every statistic out there. We didn't believe them. We really wanted to push back on that. And we thought we need more space. I mean, that's always been the mantra, right? We're outgrowing our clinic. We need more space. We need more space. And so actually, about 3 months after they told us this, we finally said, well, maybe we should analyze this. So we did some analysis, and that's what I'm going to share with you. Clinical workflow, we've always heard, work to the top of your license, what can you do? Making sure that everybody is working, and how do we pull, from the provider, as a provider myself, a physician, like, it's overwhelming to see patients, and there's so much going on, and the needs of our patients are just, immense. And like, how can we allow our physicians to focus on caring for patients, increasing physician well-being and satisfaction, which is huge, right? A lot of people are leaving more stressful kind of FQ or models because it's much easier sometimes in other clinics. My wife worked for Loma Linda's private clinic for multiple years, and then she moved over to the FQ after a couple years. And she said it's a night and day difference. It was so easy. Patients knew, it was Loma Linda's clinic, so it was mainly their employees who are healthcare providers and nurses, so they understand their diabetes. And then you come to the FQ and you have a patient who's been diabetic for 10 years and says, is a sugar of 250 high? And it's like, after 10 years, they're still unclear of what a high sugar, is, right? And so it's definitely very different. And so how can we allow our physicians and our other providers and clinicians to actually have a well-being and satisfaction that will keep them engaged and staying with the clinic long-term? And then improving access has been a huge issue for us, trying to get more patients in, and how do we do that? And so we found a way to increase our access and visit volumes 50% in one clinic. And we'll talk about that. And then leveraging technology, I believe that, and we'll talk about what I believe is the biggest benefit to clinicians in the past 25 years. So I finished med school 25 years ago, and this to me is the biggest benefit in technology that I've ever seen, and I hope it gets even better. And then we'll talk about finance and how we tripled our profit margin in 2 years. Now, the caveat here is I don't know if that's going to happen to everybody. This is something God gave us the wisdom on all these things, and I always give him the glory for everything. And I think with the profit margin, you'll see how this is tied directly to something that God has blessed us with. And it's not necessarily a guarantee that happens, but God has been good in that realm for sure. So let's talk about the first area, which is the operations. We like acronyms, so we created some acronyms, PRO and CRO. So now I thought we should add QUID, and it could be QUID, PRO, CRO. But we couldn't figure out anything that would go with QUID. So we're just doing the PRO and CRO. So patient registration optimization and clinic room optimization were the two areas that we started with. So what we did with patient registration, we're a complex clinic. We have these residencies, and the problem with residency clinics is that they wanted to do so many types of visits, and they wanted to do so many ways of seeing patients that we had 60 different visit types just in our pediatric clinic. 60. Like, how in the world? Like, it's like a new well child, a return well child, like a new who knows what. I mean, I don't even know how they got 60, but over the years they kept adding more adolescent, well child, and it's like so. We said, okay, that's too complex. Like for our schedulers, you're trying to figure out where do you fit into 60 different visit types. And over the years, we just added more, right? This is what happens, It's like we're good at, as physicians, to, add more medicines, right? Polypharmacy. How often do we remove medicines from patients, right? It's pretty rare, right, that we do that. The same thing happens in scheduling, right? We keep adding visit types year over year. So we said, we're going to decrease it down to 12. There's only going to be 12 types of visits, right? This is going to simplify it. We're going to create a decision tree. And then a reason for visit, right? Then we had all these reasons. We had hundreds of reasons for visit: runny nose, sore throat, vaccinations. And we're like, we have to make our reason for visit. And we just said 43 reasons, 12 visit types, but 43 total reasons you can visit. And that's it. But this helped to decrease our scheduling errors. And then we said, we're going to digitize all the forms, and we're going to have patients do it before they arrive, especially in pediatrics where there's so many forms, and especially, with Medicaid, there's so many forms that have to be filled out. So digitizing all the forms, we're still not 100% digital, but we're about 80% digital with all the forms that they can fill out even before they arrive at the office through MyChart or through their electronic medical record. We have Epic, but everybody may have a different. Obviously, there's different systems. And then with clinic room optimization, our goal here in our internal medicine clinic, we said, let's try to reduce our patient time in the exam rooms, right? This is, sometimes this happens all the time, right? We're really fast at getting the patient into the exam room just for them to sit in that exam room for like 20 or 30 or 40 minutes, right? And it's like this idea that, one doctor has to have 3 exam rooms. Well, guess what? I can only be in 1 exam room. So why do I need those other 2? Because the patients are just sitting there waiting for me in the other 2, right? And so how can I use my space more efficiently, right? So how can I reduce the time that the patient's sitting in an exam room? Because our exam rooms are kind of boring, right? They're just 10 by 10. There's really nothing exciting. The lobby is a little more exciting because at least they can stare at other people. But exam room, they can't stare at anyone else, right? And then how could we allow providers to see the same number of patients using less clinic rooms, which is always, but I'll tell you, taking away exam rooms, I have 3 exam rooms, you're going to only give me 2? Now you're going to give me less than 2? I mean, there was some pushback for sure. So we decided, let's move our vitals, triage, and questionnaires outside the exam room. So we're not going to vital in the exam room. We're not going to triage. All the questionnaires is all going to be done outside the exam room. So we have a little area that we do all of that. And then we're going to send the patient back to the lobby until the provider's ready. And we're only going to assign 1.5 rooms per provider. You can tell the providers are like, what? How am I going to do that? I need my 3 rooms. But no, you don't need your 3 rooms because you can only be in 1. So what happens is that 3 rooms are assigned to 2 docs. So you actually have a flex room. And that's your 0.5 room. It's a flex room for the 2 doctors because they're inside these rooms. By the time you have this flex room, by the time they're discharging patient, that patient can move in, or they can come from the lobby, which only takes a minute to come from the lobby, right? You think this through, there's really no reason for them to be sitting in these, exam rooms for all this time. So we did this. This was actually back in April of 2024, so 2 years ago. We did the control because we said, okay, we need to take our data and we're going to control that, and then we're going to do the pilot in July. The problem with July was that residents start in July, right? And so there was a limitation because now you have these first-year residents, and we love our residents, but first year, first month, man, they're green, right? And they're just finished med school, now they're a doctor, right? They have this title, but it's just they're new and it takes a little while. So that did kind of limit some of the data, but overall data for this, actually we found that the total visit length, that's the total from check-in to check-out, actually decreased by 12 minutes, which was like 15%. Now, our visits are long. You'll see the data. They're over an hour, and that's not uncommon for a teaching clinic, but they were a little bit on the long. But to decrease it by 12 minutes, that's actually a patient satisfaction metric. So total patient time in the exam room, now this is like time that they're sitting in exam room, you can imagine that this decreased by 17 minutes because this is basically the time they were waiting before they saw the doctor, right? They're still in the exam room for the exam and for the, the physical and when the attending comes in and there's like, for us, the attending has to see the patient to make it a billable encounter. At least in California, that's a requirement. So the patient still has to be in the exam room, obviously, during all of that time. But that was a 25% decrease in the time that they were in the exam room, which is huge. And it actually, the attending time in the exam room actually increased because they had a little more time. They felt like they could spend a little more time, or maybe because they were being watched, they spent a little more time with the patients. I don't know, but that did increase. The waiting from check-in to triage decreased by almost half because now we didn't have to wait for a room, right? We could triage them, we could vital them right away, right? Because you're not waiting for a room, you can just vital them and they can go back to the waiting room. I mean, basically their waiting room, back to the vitaling area, then back to the waiting room. And then the waiting in the exam room for the provider decreased by 30%. That's at 17 minutes. And then even waiting for their after visit summary, which is like our printout that we hand to the patient, decreased by 28%. And then the time with the attending, this looks really impressive, right? 40% increase. That was 2 minutes, by the way. So it meant that they weren't spending a lot of time before. So that 40% bump was a 2-minute bump. So we figured, well, this pilot really seems to show that there's an improvement in room efficiency and there's a reduction in patient idle time, and the attending can actually spend a little more time with the patient, which we thought was good. So this is the control, 87 minutes. That was our total visit length, 87. That's a long time, right? That's an hour and 15 minutes, or no, an hour and 25 minutes, right? That a patient is sitting at almost an hour and a half, right? And we decreased it to an hour and 15 minutes total. And that probably in most of our teaching clinics, it's probably around 60 to 70 minutes. Internal medicine, the patients may be a little more complex, so they take a little longer. And again, we have the PGY1s there, so that's probably one of the reasons why those times are a little bit higher. But the total time in the exam room, you can see this decrease from 71 minutes sitting in an exam room to 53 minutes. Again, the 53, they still had to be there for, the time that the resident was with them, the time that the resident presents to the attending, the time that the attending comes in and sees them, and the time before the MA checks them out. So that was still a 53-minute, but down from 71 minutes. And then this is the attending with the patient, 7 minutes to 9 minutes, that 2-minute increase, right? That almost 3-minute actually increase, that was the 40% increase of the time that the attending spent with the patient. Okay, so that's kind of, at the end of the day, how we were able to use a lot more space. Like we were able to just 1.5 exam rooms, right? And so if your doctors, if you feel like I don't have space, that is, the reality is you can make this work. Right, we made it work, and this was a huge blessing for us with the clinic room. And at the end of the day, we were able to see 20% more visits in that same clinic, in that same clinic footprint than we had seen, previously. And so you can make an increase in your efficiency for sure. Let's talk about clinic workflow, our number 2 item. And this is what we created, a nurse message center. And we were trying to, okay, if everyone's going to work to the top of their license, how can we move out so many of these issues that can bombard our clinicians? So we created a department that was going to be dealing with all the communication between patients, all the other facilities and healthcare providers. So we have nurse practitioners that we've put into this message center, along with RNs, LVNs, and then call center agents to be able to take in the calls and then direct them appropriately. So the workflow is that all the clinic functions come in, so patient messages. This is like your Inbasket. Like, how many physicians love their Inbasket? I don't see a hand. Okay, so there you go. It's like there are so many like messages and refill requests and so many things that come through. And then the problem is sometimes these things come through and the physician isn't there or not available or busy in clinic, and then it takes a day or two to get an answer. And that patient needed that medicine like right then and there that day. And so this has really helped to ensure continuity of care, closing the loop. And our nurse practitioner, when I talked to her about this, she gave so many stories about patients like who needed something, within that day, and she was able to take care of it and refill those medicines. And it's been, a huge blessing to have this. And now the blessing is that I don't have to worry about my Inbasket, right? My nurse practitioners are taking care of that. And like sometimes I open, I'm like, how did they already like respond to this? Like they like typed this like 5 minutes after it entered my Inbasket. They're like taking care of it. And that's a huge, huge blessing. It's a huge provider satisfaction metric. So again, strengthens the partnership between our nurses and our physicians and our other providers. And it's huge. So what happens is the call center agents, right? They'll get the calls in. They respond to the incoming calls by generating messages, and then they direct the nurses, nursing staff to look at it. The LVNs then filter through, and anything an LVN can do, they take care of, right? So there's a lot of stuff LVNs can do. Whatever they can't do, they forward to the RNs. The RNs will do whatever they can do, right, that's allowed, and then they forward that to the nurse practitioners, who then can actually deal with anything that requires a higher level. So for a while, we were actually making these billable encounters, right, because to support this, it's kind of expensive, right? You have nurse practitioners, and you have RNs, and you have LVNs. That's an expensive model. So we actually had the nurse practitioners, if the patient needed something, they would actually call the patient, they would talk to the patient, and they would make it a billable telephone encounter because they were refilling a med or they were doing something clinically that could be billable. The problem that we encountered when we started doing this is that not all patients are created equal in the fact that sometimes they have like copays. So we would be calling a patient, they would talk to the nurse practitioner, and then they would get a copay from their insurance. And they would be like, I never scheduled an appointment. And we're like, but we called you and we refilled the medicine. But they weren't expecting that to be like a billable encounter, right? So we ended up pulling that back and said, okay, this is just a service we're gonna provide and we're not gonna bill. But there is a way to make this sustainable and make it billable telephone encounters. I think most states still allow telephone encounters to be billable, right? Because COVID has extended that allowable billable under an FQ model. So that is some way to actually create this as a more financially sustainable. This is the volumes of what we get in a month, right? This is just for our nurse message center, but 11,000 refill requests, right? This is, when I'm teaching residents, I'm like, can you write a 90-day supply of meds, right? And like 2 or 3 refills, because every resident wants to give 30 days with like 1 refill. And I'm like, how many Inbasket, messages you're gonna get when you're only giving a 1-month supply of a medicine that somebody's been on for like multiple years. But we get so many refill requests, so many Inbasket incoming messages. So for our nurse folks to be able to take care of this is huge. It's a huge blessing. So here's specific things that the nurse practitioner will do. And again, these are higher level that an RN or an LVN can't do. And but it's a lot of stuff that they can be ordering and doing because they're providers. And it helps tremendously. Okay, number 3, improving access. And again, this really will apply if you have some access challenges. Maybe not all clinics have that, but we had a major access challenge in our clinic where today we could hire 10 full-time clinicians and we would fill their schedules. I mean, that is, we know this, and we are way behind as far as our access. And so about a year ago or a year and a half ago, we said, this is a huge issue. We created same-day visit slots, and they would fill up a week before. And I'm like, well, they're called same day for a purpose, you know? So do any of you have that problem? Like same day, and they fill up, right, a week before, sometimes 2 weeks before. And it was like, so we had no same-day access. If patients walked in or patients called that morning, we had nothing available. And so that was a major issue. So we said, okay, let's create something like, we're gonna call it Express Care, and it's gonna be a completely new type of clinic that we run. We didn't want to use the urgent care term because there's so many regulatory things and requirements that come along with urgent care. For our local health plan, it does require you, if you're in urgent care, to be open 365 days a year, and we're not open like that. We don't even have weekend hours right now. And so we said, we're just going to call it Express Care, and we're going to hire, because we had a harder time kind of hiring physicians, we're going to hire APPs, and we focused mainly on nurse practitioners for our staffing model for this Express Care. We started in the family medicine clinic because that was a clinic that had probably the most demand across our clinic system. So if you look at in the year 2025, we had 22,000 visits in our family medicine clinic, but we had 11,000 visits in our Express Care. So we start this Express Care, and literally in that 1 year, we see 50% of our family medicine total, and that's as many as they can see. 22,000 is like the max the family medicine clinic can see. We can't see more than that. We don't have enough providers to see more than that. So we increased our access and visit volumes literally by 50%, going from 22,000 to 33,000 visits total in this family medicine clinic. And the nice thing is the no-show rates, because they are same-day visits, they're more likely to show. It's still surprising to me that there's a 15% no-show rate when you call that morning for the appointment. But our average is 22% across our whole system, and I don't know how that compares to other FQs. I've been told it's around that 20% or so, but this isn't not only us doing this. There's other federal clinics I know doing Express Care. There's another federal clinic, it's through the county system, and they've been doing Express Care visits. They do 50,000 visits a year with their Express Care. So it's 5 times the amount of volume that we're seeing. And we probably could see that same volume if we had enough providers to expand our Express Care. They use physician assistants for their model, and they contract all that out. It's 100% contracted with Vituity, which is like a physician group that's national, by the way. So I don't know if Vituity is available where you're at, but they're using Vituity, who are using physician assistants and creating 50,000 additional visits for them, and they just pay a flat fee per visit for those physician assistants to see those patients. So this was huge for us and really increased our access tremendously, and we're continuing to try to grow it and expand it. Let's talk about technology, AI tools, right? I would say some of the biggest things are AI scribes, right? That's huge. I hope all of you guys are using some kind of AI scribe because there are a lot of companies out there, and they're actually very inexpensive. They're not expensive at all. Typically less than $100 per month per provider. And sometimes you can even get better deals than that. We use Nabla, but there's so many out there. There's Abridge, there's Nabla, there's Copilot, the Microsoft product, DAX Copilot. The only reason we use Nabla is because it's actually free for residents. So if you actually have a teaching center or you have residents, they can get Nabla 100% free. And with 500 residents, we thought, that's great. We'll save money on the 500, and we'll pay for, we only have full-time, only about 60 FTE. So we're just gonna pay for the 60 FTE and then get 500. And those residents at 500 are only probably 30 or 40 FTE equivalents, right? Full-time equivalents. It's not because they all come, sporadically. But AI scribing is huge. AI interpreter services, this is available as well. We spend a couple $1 million every year on interpreter services. With 280,000 visits, we spend a lot on interpreter services. Using an AI interpreter can save us significantly. And No Barrier is the one that we're currently using, the AI interpreter, and it's excellent. I've used it. It's very good. It actually picks up in Spanish. I'm bilingual, and so with Spanish, I'm able to speak, and they'll pick up even colloquial terms, and even be able to distinguish, terms. We have a large Mexican population, but there's also other Central American, and they'll be able to pick up the differences between terms that are used in Mexico versus Central America or South America, and it's actually quite good. And there's some evidence or some benefit with that as well. And then open evidence, hopefully, I've been told that 60% of clinicians are using open evidence now across the US. It's huge. It has now, a couple $1 billion value, the guy who started it. And it can be integrated now even for clinical decision-making, not just a website or an app that you go to, but actually integrated into the EHR to guide you on making decisions for the patient. And even for billing now, they just came out with a billing to let you know what E&M code to apply based on the visit as it analyzes the documentation. So I think the scribing tool is huge. There's evidence from large health systems showing a lot of measurable reductions in the documentation burden. Of course, the savings will vary by the study and workflow and level of adoption, but these are a couple statistics. Kaiser Permanente, they actually use a bridge, and KP is the largest healthcare organization across the US, and they reported almost 17,000 hours saved in 1 year across millions of users, equal to 18,000 8-hour workdays. UCLA, which is Los Angeles, 238 physicians, 14 specialties, over 70,000 encounters, and they said they reduced documentation time by 10%. I think that's actually not, I think that's underreported. Because my personal experience is that I save at least 5 to 8 minutes per patient encounter, which to me is a 50%. That documentation time that would normally take me, 15 minutes to document now takes me 5 minutes. That to me is a much bigger reduction than just 10%. And I can focus on the patient while the AI is actually typing up the note, and that's so much nicer to have that face-to-face, eye-to-eye contact with the patient versus having to be typing the whole time that I'm talking to the patient so that I can get my charts done. Because I was always the type that I had that chart done and signed before I went to the next patient. That's how I always did it. But the only way to do that is that you're typing the whole time you're sitting there talking to the patient, which doesn't feel very, very good as far as interaction with the patient. But AI Scribe is amazing, and that allows that to happen much, much more efficiently. From a productivity standpoint, UCSF, that's San Francisco, found that AI scribe adopters generated more RVUs. Probably not something that really applies in our FQ setting because we don't necessarily need higher level of billing, but if we can see more patients, then that would be great. Same studies showed that they could see 0.8 more patient encounters per week. I think it's probably 0.8 per half day, but 0.8 per week. And then, of course, claim denials, because it's okay, is this documentation correct? What's happening? Is it going to be denied? Are you still going to be able to bill? And at the end of the day, I think the notes are actually more complete and more thorough than my previous notes where I basically did an abridged version, right? You're always trying to summarize what the patient's saying. You're not going to type every word, but an AI scribe actually puts in a lot of words. And you know what I always found fascinating? because I used AI Scribe. I went to Guam last year and covered a year at a clinic there, covered a month at a clinic there. And they had the scribing, even before we had it in Southern California. I'm like, how does Guam have it and we don't have it? So I came back and I'm like, we've got to get this, because if Guam has it, like, why is California not have it? But at this clinic in Guam, I was there for the first time. I'm talking to patients, and like literally, a third of our visit was how nice the beaches are. And they were telling me all the beaches I need to visit. And I just thought, is this going to be put in my note, right? And so they would talk about all these beaches. None of that was put in my note, except one time the patient said, there's that beach you really need to visit. I had a near drowning accident there. And I'm thinking, well, why are you recommending I should go there? But apart from that, they mentioned that. And then the note, it actually put, they had a near drowning experience at that beach. Because that's a clinical issue, but it knows what to pull out that's clinical versus not clinical. And so I think that's fascinating. So it's like a real human scribe. This is, I think, really key here, because we know that there's physician burnout, we know there's provider burnout, but this multi-center study found that burnout dropped by literally this 13% just after 30 days of using an AI scribe, right? That's huge, right? So again, it's very inexpensive compared to a human scribe where you're going to be paying per hour for them. This at a less than $100 a month, that would be the equivalent of 4 or 5 hours of a human scribe in the whole month, and it would only be like a half a day of a human scribe. It's weird I'm having you say human, but. And a half day of a real human scribe is the equivalent of paying for this for a full month. Let's talk about the interpreter, the AI interpreter. The nice thing about an AI interpreter is that they're available 24/7, right? So it can be faster, easier to schedule and to scale. At least a 50% reduction in costs is what we found from what we've been paying for in-person. And sometimes our in-person or over the phone interpreters or video interpreters, because we use everything over the phone, in-person, and video. Sometimes the quality of the interpretation isn't always great, right? It varies depending on the individual. And I think so some of this with the AI is actually higher quality. And, when you add an interpreter, especially an in-person, into the mix, there can be more kind of friction, especially in a high-volume clinic. And we found that patients feel sometimes more comfortable sharing things when it's an AI interpreter versus a person, especially in small communities. Like if we have like a patient from Afghanistan and there's an interpreter there, that may be, that community is so small, like where we're at, they may know each other or know of each other, and they may feel very uncomfortable sharing personal information, like, exposure to STIs or something else, right? And so with an AI, they can feel a little more comfortable because it's not, it's a little less personal in that sense. And then the open evidence, this is really, really nice how it can be integrated. We're only a couple of our providers are integrating it currently into our Epic, but it can be integrated and help us guide on diagnosis, treatment, and management apart from, again, the separate app. And studies have shown that the recommendations that they've made are accurate and aligned with what the physician or the provider would already do. And again, the nice thing when it's integrated, then you don't even have to leave the chart. You can use this in the search function without leaving the chart, and it can actually give recommendations on how to manage the patient based on the history that's been given. And this is free. Open evidence is fully free, being funded by advertisements, and it is a fully free thing. So how it can be engaged in the EHR would be great. Typically requires an MOU between open evidence and your clinic to integrate it with whatever electronic medical record that you have. And then finally, I'm going to focus on the financial aspect. a couple years ago, we felt impressed to give back 10% of our profit margin. God was blessing us. We had a profit margin, and we wanted to give back. And I asked around, and I thought, do organizations do this, like organizational tithing? And not a lot did. I talked to some other even Christian hospitals, and they say, well, there's so much community benefit grant that they give, and so much free care that they provide through their emergency room that they've never really thought about giving like an organizational tithe, because they feel like they're already doing that with so many other areas that they're losing money on. I met with our CFO, and he had experience previously from a small private Christian school that he had worked with. And in that Christian school, they only had like a $20,000 margin. But they had committed to give 10%, so they gave $2,000. The next year, their profit margin increased to like $60,000, which was like doubling, And then they gave $6,000, and the next year it was over $100,000. And so they saw that when they committed to that $10,000, God blessed, and they increased, their profit margin. So we decided, well, how are we going to give this 10%? Because we're not connected directly to any specific like church or specific denomination. So we decided we'll start a foundation, and then we will funnel 10% of the profit margin into that foundation that will then go back to the community. And, I looked this up. There are some Christian-owned companies that do this, right? That do a 10% to ministry or maybe to charitable giving. And usually people will say that, let's do it based on a net profit versus like your total gross revenue, right? Because that could become, much more costly to do. And then some also will say, instead of giving money, let's tithe our time, right? And have employees give back and volunteer, a percent, potentially up to 10% of their hours back into the community. So there's different ways of doing this. And some of the organizations that do have something like this include Hobby Lobby, Chick-fil-A, Tom's of Maine. These are all Christian organizations that do some type of giving back to the community at like something similar to an organizational tithe. But for us, it really was a blessing. Our profit margin tripled in 2 years. And it wasn't $20,000. It was millions. It was millions of dollars, and really it was $6 million and went to 18 million. And that's what we saw in 2 years. And I can't really explain it that it was just that we saw more patients or that we decreased cost. It really was, I believe, God blessing. And when you read Malachi 3:10, and it talks about bringing, to God. And he will provide. We have seen an amazing amount of outpouring and blessing as we have done this, and it's just been tremendous. It's been huge. And so I know not every clinic, may be even having a margin, right? And some clinics may even be struggling in the red. But if there is a margin, I believe that, just like God calls us individually to give back, I think organizations can also be blessed by giving back. And we have definitely seen that 100% in our experience. And it's been a true blessing for that. So those are the areas that we've been doing the last couple of years. And I appreciate, having you guys join. I hope if there's something you guys are doing, we'd love to hear what you're doing that has been a huge blessing to your community, and what things that you have done to kind of optimize and improve. I think, is this session 5 or is it session 4? Okay, so I'm good. I did put this slide in here. Question?
Hey, really appreciate it. This is great to hear this, Jason. For just your regular family medicine, non-resident driven, clinics, what's your goal? What's your target volume of patients for internal medicine clinic? What's your target?
11 patients per half day.
11 per half day.
Yeah. And we're happy if they hit 10. But 11's the goal. Yeah.
Okay.
Yeah. Go ahead.
So in the beginning of your speech when you're talking about clinical flow and all that, and some of the things taking the rooms away from your providers,
Yes.
you mentioned the word pushback. And so I would like to expose a question for you to explore with us. What was done in your office related to that pushback as you began to roll out things, and how was that handled professionally? And I mean, with teleprovider, we're taking the room away.
Yes.
That does not bode well. And they're
Right. No, I mean, and we still have pushback even today. So, because we're moving it from clinic to clinic. And so, but being in an academic setting has been helpful because it's like, well, we're just doing this. You could present it as like a PDSA, right? A plan, do, study, act. You could present it as just like a pilot project. You just want to see. I mean, there are ways to like sell it. And typically people want to see improvement. And today, if you ask the pediatric residents, the chief residents, I was talking to them the other day, and they're like, I really like that things are changing. We're seeing improvement, we're seeing change. Change is scary for people, but when you see change and there's an interest ultimately to help the patient and the community, right? That's the heart of it, that's the focus. Then it's really hard to like say no. Like if you say, this is gonna help the community, are they gonna say, well, I don't wanna give up a room? I mean, they could still say that, right? They could say anything they want. But at the end of the day, if you present it, and this is really going to increase our access and our impact that we're having, right? Very few people are going to stop, and block that, and just say, it's a trial. We're just going to do it for 1 month and see. And then once they see that there is a benefit, then they buy in, right? But you have your early adopters and you have your late adopters for any change. But that's how we've done it. No problem.
You may or may not have faced this problem, but I love the space saving, like the room distribution, but I often bounce between rooms. So I'll leave a room. I'm like, we got some referral information we need to get. Hey, you can go check them in, and then I'm going to So I'm imagining that came up. How did you solve for that in terms of once the patient's in the room, the provider's there, I'm kind of viewing it as when you leave, you're done. But that's not really what happens for me in practice. So what do you guys do to solve it?
Yeah, that's a good question. I don't know. Because I think we've just forced everyone to not do that, right? Because this is all you get, right? I'm sure there are doctors that do. There's got to be, right? That's not been my style, so I've just assumed that maybe that's not everyone's. But of course, with the residents and with all the attendings that we have, then I'm sure that's somebody's style. And maybe we haven't even hit that yet because we've just done this in the pediatric and internal medicine clinic. And I think maybe they have had that, and the people who've been doing it have a lot more data on it. But that's a good point. And I can find out and get back to you if you want to give me your contact and see. I think it is kind of potentially forcing people to do a little bit different style when they're seeing those patients. Yeah. It's my wife.
What happens is there's also an overflow room. There's something, because I think what used to happen to me, and of course I haven't been cut back to 1.5, I would die, but I will personally complain to the CEO. But the point is that what I've been seeing is that if there's anything, because there used to be a delay when I would order a immunization or something like that, and then that room would be locked up. So there is a room where people are moved to do, waiting or, something that takes a long time. So I think there is, maybe it's not exactly 1.5 or whatever. I think there's a little room for error so that you could potentially, have that cushion. That's what I think.
Mm-hmm. Yeah, there's, Carol, do you have a question?
Yeah. Do you get patients complain because when we were very small and limited space, we do that? But then patient complain because they get intake, they go back to the lobby, they go back to the exam room, they go back out, and then they go to the, in an injection and lab, they go back out. It's especially elderly. They have to be moved so many times. You don't get patients.
Yeah, we only move in the one time. So it's only after vitaling that they go to the waiting room. And then once they're back in the exam room, they're there for whatever needs to be done, even vaccines. Yeah, we don't do blood draw in the clinic. We have a lab on site that does the blood draw, because that always took so much time doing the blood draws. But vaccines, of course, we do on site. We've tried to do a vaccine separate room, but it doesn't necessarily work. It doesn't really make things more efficient in our experience. I don't know. Yeah.
So like in terms of workflow, so you're having patients get triaged not in the room. Is there like do you have a room set aside for that? So it's like a little bit more private?
Yes.
Asking questions like, how does that basically look like?
Yeah, it's like a little walk-in kind of cubby space, and
So your clinic was already designed kind of with that in place. I'm just trying to think like
no, it wasn't. We had to actually put that in because we didn't have a space. We had this little room that it was supposed to be for the referral coordinator to like set up referrals, and then the patient was going to get, those appointments made when they walked out, and we converted that space into the vitaling area. So it did take a little bit of conversion to make that work. Yeah. Let me get the question back there.
Yeah,
Is-
I'm curious on the AI scribing, which you know is less common languages to read or use AI based practice as reliable. And then how many patients feel, I know they like the eye contact, our patients are often concerned about what the AI is doing and things to get rid of that.
Yeah, great question. The list of languages that AI does is pretty extensive, but I'm not sure if it goes into very specific, all those languages. I would have to look and then see the quality of that. What I'll tell patients is I'm going to use the computer to listen to our conversation and help me write my note. Is that okay? But it is HIPAA compliant. It gets deleted. It's, if they ask questions, I'm questioning that. I'm like, it all gets deleted. It's all private. But there are sometimes patients say no, but 90% of the time they say yes. And if I say, it helps me so I can like focus on taking care of you. It's like having a person in the room typing the note. Like there's certain ways to. Yeah, I mean, if they say no, I don't do it, but I hope they say yes. I really do. Yes?
With the express visits, do you find, I assume there are certain limits, like you got to talk about one thing, we're not going to talk about your renal failure and your hypertension and your depression, if you're there for the cold. But do you find that some patients think, well, I've been seen now, so it delays the care of their chronic illnesses because it's a long wait time to the next routine appointment?
Yeah, to be honest, we try to keep the express care visits even broader than just one issue, because we do know it is access for them. And so even hospital discharges will sometimes be seen in express care. And those are complex, and it can overwhelm the nurse practitioners that are like taking care of those patients. But to us, it's not just limiting it to one or two things. It really is kind of like a real clinic visit. Then where it impacts is continuity, right? Because we can't get that patient in with that, with doctor or provider. So it's not great for continuity, but at least it's good for access. And so you're trying to balance the access and continuity, Yes.
Obviously, you are very profitable, which is a testimony to your excellent management. And you tithe 10% of your profits. What comes to the other 90%?
The other 90%? Well, it goes back into capital projects because, like currently, we had a building that we needed to renovate, and it was an $85 million, the total $120 million project. And we needed $85 million. And that's another answer to prayer, because the banks would not give us a loan at all, because they're banks and apparently they don't give loans. And so it was a private Christian family that gave us an $85 million loan. And the real estate attorney who created that deal said, I've never seen it in my life. And she worked 40 years in real estate. And I said, well, it was God, right? Because this family, I've never met this family. But they have enough money to give us $85 million loan. And that's been a huge blessing. Yeah.
I think it's simple as that intake and digitizing it has been a challenge for us.
Yes.
So far, I think it's because of our low literacy rate like not even helpers, even like the general literacy.
Yeah.
Do you know if it's was that in fact, was that a clinical processing, you know, switched in the clinic?
You know, I think we're still dealing with that, and we're still looking at what that's going to look like, because with just 80% of the forms digitized, and we hope that people can do it ahead of time, but a lot of times they come and then they need help, right? They need help from the MA, or they need help from somebody to fill out that paperwork, and of course that slows the process, but there's just no other way for those folks who are having a challenging time answering the questions, right? So I know we do have, I don't know the exact number of our low literacy, but it's a challenge because we don't have those in every language either, right? And so depending on the language of the patient, we will not have the forms, right? In Farsi or, other, less common languages.
As in if it's increasing for all the staffing time?
So far, we don't have a lot of data on the patient registration side. And so, we'll have better data probably, in a couple months, but we don't have a lot of data on that side. We're hoping that it won't increase, but it could, and if it does, we'll have to kind of pivot. Yeah.
Question about the AI translation that you're using. So it sounds like you're using it in medical business.
Yeah.
From a compliance risk management standpoint, I know some of those sorts of organizations have read on this and felt like it's not really yet an AI translation approved for things that you consider moderately complex decision making. Like it's not a person, it's not visual. So I was kind of curious what some of your research around that is giving the comfort level to use it as a tool.
You're talking about the interpreter, not the scribing.
Well, I think generally like, AI is considered not technically color interpreter, but translator, because interpreter implies actually a person.
Yeah. I mean, it is the No-Berry is HIPAA compliant. I think it was developed by a company out of Israel. And it's HIPAA compliant. It does, it can integrate into EHRs, but these are still all new. The interpreter AI is the scribing has been around for over a year and a half now, but the interpreter has only been around for maybe 6 to 12 months. And so it's all kind of a new area, but it, at least in Spanish, for sure, it is good, and it's been very useful, and it's in some ways better than our in-person or video or telephone interpreters. Yeah. Yes.
Talk a little bit more about the inbox and what things still end up in the provider's inbox and what nothing.
Yeah, we haven't turned it on for all providers, and in residents, we still feel like they need that experience because, the joy of inbox management is really a critical piece of residency training. That's how I word it. And so it's not for everybody, but for our direct care providers, like our docs who are attending physicians that are seeing, the majority of our patients, that it is turned on for them. And so it's the majority. It's only times where they have questions, maybe for the provider of, are you comfortable with me giving this refill or doing this medication? And then the nurse practitioner will send us individual messages. So I'll get a message from her saying, oh, should I do this? And then I say, sure, or thank you, go ahead. So otherwise, the goal is to pull all of that out. And so then only maybe 10% of the time they'll have a question that they have to ask us if we agree. Yeah.
Can you talk a little bit about the kind of formal or even informal training that takes place as integrated AI tools? Is that something that your medical leadership is responsible for, especially with a number of residents that are in your clinic, or do you have a MR team that oversees that, or
Yeah, it's complex. The last data we have, there's only 37 providers using Nabla, right? Which I think is crazy. But because, we have a lot more than that. But some of the residencies have had, they've been hesitant to start allowing the residents to use the AI scribing. And so, every residency has their own opinion on this, right? It depends on the program director. And so some are saying, well, third years can start using it, but not first and second year residents, right? They need to learn how to type a note. And I'm just thinking, well, in 5 years from now, I guarantee you first years are going to be using it, right? I mean, and so they're not going to learn how to type a note. So why do the current ones need to know how to type a note, right? I don't need to know how to type a note. Like, at some point, but I understand. So it's been interesting that we haven't had as much take up of the AI tools that I would have imagined with only 37 people using it. And then the interpretation has also been like a slow rollout because it's convenient for people to just use like in person or a video, and that's kind of their normal workflow. And using the AI has been a little more challenging. So we roll it out to our clinics, to our medical directors of each clinic, to the program directors of the residency, but it all depends on those individuals, how much they're going to push that. And we haven't been like requiring it because we just think it's a value add. But I think at the end of the day, it'll be positive experience for them. So hopefully they will adopt it at some point. But good question. Thank you all. Appreciate it. If you have any other questions, I'm still here.